Welcome to Garage Gym Athlete Cooldowns. These episodes are short, actionable podcasts pulled from previous interviews and content we've been publishing for the last several years. So go for a walk, hop on the rower, or clip into the bike for this cooldown episode.
Sure. So my background, so I'm an athletic trainer. I got my undergraduate degree at Grand Valley State University, and then I went on to the University of Virginia and got a master's in sports medicine. At that point, I stopped sort of working clinically, meaning I wasn't necessarily interacting with outpatient orthopedic patients anymore, athletes. I decided to pursue more of a research route that's sort of centered around strength. And the reason for that is I found that oftentimes when I was treating my patients clinically, I would be doing some sort of treatment for X amount of time because that's how insurance reimbursed you. And everything sort of became cookie cutter, and I just really wasn't a fan of that. And what I wanted to do was sort of change it up and say, you know, are there different types of therapies, different types of exercises, strength training that our patients or our athletes could be doing that could sort of optimize results that aren't necessarily based on like a pre-programmed recipe for everyone. And so that sort of drove me to go back and be someone that sort of creates that literature. So then I went on to the University of Michigan and got a PhD in kinesiology there. And I primarily worked in the clinic with folks that had suffered major knee joint injuries and trying to find ways to help them recover their strength that are different than the current standard of care. And then from the University of Michigan, I went on to the University of Kentucky and did a postdoc and sort of shifted focus a little bit there, looking at muscle sort of more in depth. And then since 2015, I've been an assistant professor at UConn, running a couple of labs looking at muscle recovery after injury.
Okay, awesome. And what kind of research are you currently involved in?
Yeah, so my lab has two different sides. We have a side where we run a full-blown human lab where we look at people that have had major joint injuries. Specifically, we typically focus on the knee and ACL injuries. And we look at sort of how the muscle changes after an ACL injury as a model of joint injury, and then also different types of rehab that can help people optimize muscle health after that joint injury. And the motivation behind that is ACL surgery itself, and a lot of joint surgeries don't prevent early onset osteoarthritis. So you can sort of fix the joint, but it doesn't promote sort of long-term health. What we do know is if you can promote muscle health, that can sort of save the joint. So our goal in our lab is to say, like, muscle is modifiable, muscle is something that people can work on, that clinicians can work on without surgery. What can we be doing to improve muscle recovery to promote sort of long-term health and deter maybe joint degeneration? Okay. So that's one side of the house. And then the other side of the house, we work with rodents, we work with rats. Okay. And we basically perform the same type of experiments in rats that we do humans. In particular, we cause a lot of rat ACL injuries. Yeah. And the reason for that is you can control the entire environment. And then we can also sort of look at muscle on a more basic level there and see sort of what's going on after those types of injuries.
That's very cool. And, I'm excited to kind of talk about this a little bit more. Just so we can catch everyone up to speed on basics of ACL injury, you know, what are the primary way people are running into ACL problems that you see?
Yeah, so ACL injury is an injury that generally happens to sort of like a younger population. 16, I think, is the peak age. A lot of times it happens in a non-contact way. So somebody could be like running down a court on a field and they decelerate in a way that their knee sort of moves out of typical motion and it causes stress on that ligament and it ruptures. The problem with that ligament rupturing is that the stability of your knee joint is really sort of compromised at that point. So oftentimes people seek surgery to fix that. The problem with the surgery and the rehab as it stands is, we talked about a little bit earlier, but generally people don't recover muscle as well after that surgery than they do before. And there's some long-term consequences with having sort of early onset joint degeneration. So people end up having sort of a lifetime worth of knee issues based on an injury they sustained in their youth.
And so are you looking at also preventative care then, something people could do before, like possibly just to not get the ACL injury altogether?
My lab does not do that. I have a lot of colleagues that try to prevent the initial ACL injury. We're focused on the group of people that have the injury and saying, okay, you've had it. Now what can we do to sort of optimize your health going forward?
Right. And I know a lot of people, a lot of friends and athletes with torn ACLs over the years. And what would happen, it always seemed to be this way, is that, I'd be playing sports with people and they would be, it wouldn't even be our sport. We'd play football or something, and then we would go play a pickup game of basketball or something. And then, friend tears an ACL during something like that. It was never like, in my experience, at least, it was never the sport that caused it. It was always some random activity. And a lot of the ones I did see, you mentioned court, it was always court sports that did it most of the time in my limited, I'm obviously not collecting data, just talking about friends and athletes, of people I've been around. It was always some sort of court sport that seemed to jack with people. And so do you think that surgery, is the way to go for fixing the ACL injury, and then after the fact, that's what you're primarily focused on is, okay, we got a post-op. This is what we should be doing.
Yeah, I think it depends on the patient's goals. And some people are classified as what we call copers. So some people do really well when they're ACL deficient and their knee sort of, with their muscles acting, it self-stabilizes. So some people are okay without an ACL and they do just fine.
Wow.
Other people, it doesn't sort of work out for them that way, and they need sort of the reinforcement of that static stability of that ligament. So pursuing sort of surgery for them is a better option. So I think maybe where it's headed is not everybody needs surgery, and identifying if you're a person that can sort of self-stabilize versus not maybe is something that, future medicine and medical treatment could consider. But we're really on the side of house of, you've had the injury, now what can we do to sort of save the joint long term and sort of optimize better quality of life?
Yeah, so let's jump into that. What are some of the things that you are having people do to save the joint, for that prolonged period of time? And I'm sure you're talking like well into their later years. You want them to have, good movement of that joint.
Exactly. One of the topics that our lab is really hot on, it's called eccentric exercise. So for your listeners, eccentric exercise is basically anytime you load the muscle while it's lengthening. So if we're thinking about the quad muscle or the thigh muscle, when you're going down into a squat, your thigh muscle is lengthening. There's a load on it. It's considered an eccentric exercise. Basically, most of the exercises that people do right now in rehab are very concentrically focused, meaning that you're like lifting the muscle up or lifting the weight up and your muscles constantly shortening. And this is good. And we're not saying that people shouldn't be doing that, but there's sort of been a notion in the literature, which I think has seeped into the clinic, that anytime you lengthen your muscle and you put a load on it, that it's dangerous. But our lab is trying to sort of change that storyline. And we have some pretty basic scientific data and some good promising clinical data to show that if you load the thigh muscle while it's lengthening, you get some pretty good return. Your neural activity looks better, which is compromised after major injuries. It seems to help promote muscle growth much better than a shortening exercise. So it looks pretty promising. And then the other point to it is it's free and it doesn't need any type of specialized equipment. So being sort of purposeful about how you're overloading the muscle and in what sort of range, we think that there's something to that. And that's sort of one of the topics that our lab is pretty hot on.
That's awesome. And how are you guys doing that primarily? How are you introducing eccentric exercise? I could throw a few examples, but I'm sure you got it nailed down.
Yeah, so we do it a bunch of different ways. When we are like running a study, we do it in a very controlled manner. So, we can control all the environment. But I mean, you could simply do a recumbent leg press. And let's say Your right leg is injured. So you push up with 2, which would be the concentric phase, your muscle shortening. You push up with your right and your left, but then you just lower back down with your right. That would be considered
Got it.
An eccentric exercise. Walking downhill, if you have a treadmill that can do retrograde walking. Walking downhill is your muscles lengthened, and that's considered eccentric sort of loading. You could do single leg squats, and you're in a standing position and you're just lowering down on the limb that's affected. That would also be considered eccentric exercise. So there's a lot of different ways that I think that you can MacGyver movements that you're probably doing in the clinic anyways, but be more focused on sort of the downward motion when you're loading the quad. That would put you into the eccentric category.
Okay, and how long are you seeing it to take effect or for results?
If we're specifically talking about ACL people, we've had some pretty promising results where if people just train twice a week for 6 to 8 weeks, about 12 treatments, they have sort of long-lasting gains in strength that correlate to better movement later on in therapy.
Okay, awesome.
So it's really it doesn't seem to be too time invasive.
Yeah, and it's like you said, it's kind of like intermittent fasting. It's like some of the stuff that you're already doing, you just eat during a certain window. It doesn't cost you anything. And it's like what you're saying with this is like you just move the weight in a little bit different way, a little bit slower, maybe tempo or pause or whatever, and you're completely changed the game. And
thanks for listening to today's Cooldown. If for some ridiculous reason you are not subscribed to Garage Gym Athlete programming, fix that problem right now. Go to garagegymathlete.com, sign up for a free trial, get started with us today. Thanks for listening.